Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you for joining us today and our friends at Cherokee Health Systems for hosting today's session, Medication Non-Adherence, Part 2 with Dr. Fred Kleinsinger. Briefly, Dr. Kleinsinger, he is an associate clinical professor, family and community medicine at the UCSF School of Medicine. He retired after practicing for 38 years. Since retirement, he has been in active teaching first through third year medical students at UCSF. He has developed and led CME workshops on a variety of topics at regional hospitals throughout the state of California. He's published 3 articles on the topic of medication non-adherence, which is a special interest of his, and we are just so very thankful, especially me, to have him as part of MAVEN Project. So Dr. Kleinsinger, when you're ready, please begin.
Okay. Well, hello, everybody. This is part 2. I'm happy to see you again, though, of course, given the Zoom, I can't actually see anybody, but I'm hoping that some or many of you have been for part 1. This part 2 is, in its own way, somewhat self-contained, so if you happen to have missed part 1, part 2 still should be meaningful for you. In this presentation, I'm going to be talking about practical steps that one can take as both individual practitioners and as also members of a clinic community to improve medication adherence. And I always say this, if anything that I talk about, that we discuss, appeals to you, seems worth doing, please write it down, put it on a Post-it, put it on your computer, and remember to practice it. You know, if you're done with patients today, fine, or tomorrow or something this week, because my experience and the literature suggests that when you go to CME conferences and you learn interesting things, if you don't actually use them, put those tools in practice relatively quickly, they tend to fade into consciousness as other things come in and, take up your mind, which of course happens a lot to busy practitioners. So have a pad by you or a Post-it and say, oh my God, that sounds interesting. I want to try that. Fine. And I'm going to be talking about a lot of stuff. So pick the things that appeal to you the most. That's my little plea here to make this actually happen. Anyhow, the disclosures are the same as last time. I don't have any relevant disclosures, and this is accredited for CME. Okay, now we're starting. So summarizing the earlier presentation in brief, medication non-adherence is an extremely common problem. I called it an orphan problem last time because nothing about this has changed much in the last few decades, and it still remains a major problem. And by medication non-adherence, I mean that multiple studies, including current ones, show that as few as 50 to 60% of patients with chronic conditions take their medications appropriately, the appropriate definition being more or less 80%. So it's not a perfectionistic approach. And the studies which this were based were primarily done on insured patients. So when you're looking at safety net clinic patients and people who have, not good health insurance or coverage, though they may be getting medications through the clinic, it's probably worse, but I don't have data on that. Anyhow, since we believe that when people do take their medications, the literature shows that they're effective and have many benefits, the lack of taking medications correctly can cause tremendous numbers of complications, increased costs, and most studies suggest that it's more than 100,000 deaths per year in the United States from not taking medications for conditions where the value of the medications has been proven, multiple times. So that's the summary. This is a major problem. It affects all areas of American healthcare. It affects all classes of medications. I'll just mention this now because many people, when I've talked about this in the past, say, well, sure, hypertension largely is asymptomatic, but what about symptomatic conditions? And unfortunately, the studies for symptomatic conditions ranging from, say, asthma/COPD to mental health conditions are also, pretty disappointing, pretty low adherence figures. Anyhow, so there are multiple factors which contribute to non-adherence. And I list them in the previous talk because there are many reasons that it can be difficult for people to take medications. But I tend to think that the so-called barriers or obstacles that the literature are full of, the medical profession is using as an excuse for its own failure to help patients get beyond those barriers. And it is possible, as I will say in a little while about talking about One Health System, which has relatively successful with this. It is possible, it's just difficult. But that the big issue is not just that there are barriers. Oh, it's costly, it's inconvenient, I don't have the time, etc. But it's that we as a profession have underestimated the difficulty of the behavioral changes necessary for medication adherence. We grow up with pills. We're in medicine. We write prescriptions. We probably even take some occasionally ourselves. And it seems almost like a trivial thing to do compared to all the other difficult things we have to do in our lives. But for our patients, that is not necessarily true. That this is a big deal, and the statistics show that it's a big deal. And because we tend to underestimate the difficulty of this for people, we also don't give our patients enough motivation, education, and support. We tend to simplify the process. You have hypertension, the medication will lower your blood pressure, this will reduce your risk of heart attack and stroke, take one pill a day, see me in 3 months. Any questions? No. Now, I'm obviously abbreviating that sum, but nevertheless, there's a lot of truth in that summary. And because of that fairly short shrift that we give this, that for many people, this does not succeed in motivating them to really take it seriously or to see what the benefits are. So we're going to be talking about that, and particularly about communication issues here. So the goals of this presentation, we want to give the people who are attending an overview of techniques that we can use to prove adherence that have been shown to be successful. And as I was saying at the beginning, to help people facilitate a development of a specific adherence improvement plan, both for themselves, what am I going to do as an individual, and also in the practices, using whatever resources are available in your practices to help you and your patients achieve better adherence. And we're going to talk more about that. And by the way, as I said before, I will sometimes, out of long habit, use doctors as a phrase for clinicians. I really mean clinicians, since I know that many of the people here will be nurse practitioners, physician assistants, other forms of advanced practice practitioners, and I mean to include everybody in that. Just old habit, so I apologize if I do that. I really do mean to use either practitioners or clinicians in most circumstances when I'm referring to people who write prescriptions. So anyhow, now getting into the meat of the presentation, improving medication adherence. Well, there are multiple ways to approach this. No one way by itself has proven to be that effective. And the Cochrane study, and by the way, the Cochrane has repeated the studies numerous times, and they show the same things. A multifaceted approach which looks at this issue from multiple perspectives and multiple people is likely to be the most successful approach. We're going to be talking about literature-based and my own personal experience, things that can help with this. And a couple of slides I really want to call attention to because I think they're the most important, like I did last time. For adherence to be successful, the apparent benefits to the patient have to exceed the difficulties. We all have mental calculus in our minds about anything we're doing. Oh, do I want to do this? Do I have the time to do it? Which is the more higher priority for me? We need to give our patients enough information to put taking medication in the heavy part of the scale that will motivate them and help them do this. And so that's what we're going to be talking about. But most people, and by the way, you'll never get 100% adherence. You never get 100% on anything with people. We're too diverse. There are too many issues here. But 80 to 90% adherence is possible. I also will use the term compliance sometimes because it's an old-fashioned term. I don't like it. It's gone out of style because it has a sort of authoritarian feel to it. You will comply versus we're going to develop a joint plan that we hopefully will adhere to. Anyhow, we're going to talk about improving adherence. Number one, practical tips regarding medication prescribing. I want to get that out of the way. In some ways, that's very useful, and that's the simplest part. Physician, here we go again, clinician-patient communication and system approaches. So those are going to be the three components of this talk on improving adherence. Okay, practical tips. Okay, cost. Now, this is an issue everywhere, and particularly in safety net clinics, where sort of by definition there is, poverty issues with the patients and also limited resources. So anyhow, you know this, but I just want to say this: use generics whenever possible. Now, for hypertension, pretty much every medication that's in a common hypertension algorithm is now available generically and cheaply. Now, that cheap doesn't mean cheap for everybody. Some people have trouble with $10 every month or every 3 months. But anyhow, the generics for hypertension are cheap. For diabetes in the last few years, this has changed with the advent of some very expensive $600 to $1,000 a month drugs, your GLP-1 agonists and SGLT2 inhibitors. So that's more of a problem, and coverage for them has been spotty. But we're going to be talking primarily about the use of those drugs for diabetes and not so much for weight control, because that's a somewhat different issue. If your patient has poor or non-existent drug coverage, you can encourage use of low-cost pharmacies. I don't know if your area has Costco's, but you do not have to be a Costco member to use a Costco pharmacy, and sometimes their prices are very good. And a lot of the generic, the big pharmacy chains like Walgreens or CVS, again, I don't know, Rite Aid, I don't know what you have in your area, have generic discount plans. Also, there is a way, again, in case your clinics cannot provide these medications, there is a website called GoodRx, GOODRX, in which patients can get coupons that often have big discounts on medications that they can bring to local pharmacies. So that's another thing to encourage, to deal with the cost issue. Other practical tips. Try at the very least to prescribe things daily, once a day. BID, sure, some people will actually do that. Above that, we're deluding ourselves. Many studies and experience show that if you expect someone to take a medication more than twice a day on a regular basis, almost nobody will do it. That's just the way of the world. And a lot of these medications can be prescribed daily. There are studies that show that even if someone's told to take, say, some antibiotic 3 times a day for 10 days for sinusitis or whatever, that most of them will stop as soon as they feel better. People just don't take medications. Again, this, encourage use of pill boxes. If your clinic isn't giving them out, encourage them to give them out, because the advantage of a pill box is that people can set their pills out once a week. And then also, if they're not sure if they've taken the pill of a given day, they can look at the box and, oops, my Wednesday evening pills are still there. I didn't take them. Okay. Suggest taking pills at the same time each day. Make it a habit. We're going to talk about that. And associated with other habitual behaviors. If you associate the behaviors, that becomes easier to do. And again, we're going to talk about habits. Many pharmacies will mail prescription refills. Encourage this when it's possible, because I know what it's like. If you don't do that, you drive to the pharmacy, I don't know, 20 minutes. You stand online to drop the prescription off. If it's not there, 15 minutes. You wait for it to be done, 30 to 60 minutes, whatever, as opposed to mailing. Much better if that can be done. Now we're going to get to what I consider to be the most important part of this, clinician-patient communication. And why is this the most important? This gets back to the scale that's at the beginning, that this is where we can tilt the scale in the favor of taking medications by increasing patients' motivation to do so. I didn't say at the beginning, by the way, that I like interaction during presentations, and I know it's very difficult. I'm talking to Cherokee Health Systems, and I'm in California, but I'm always, I have time to interact. So if you have questions, comments, whatever, feel free to either raise your hand or put it in the chat, and I or Kristen will look at it and attempt to respond immediately. If we leave questions to the end, they're no longer so fresh in your mind, and I'd like to insert whatever I have to say at the right time. So I'm very open to being interrupted, is what I'm saying. Okay, so this is a long list of what we're going to talk about under clinician-patient communication. Shared decision-making, teach back, anticipate obstacles, self-monitoring, involve family members, build self-efficacy, use I statements, ask and listen. Those are going to be the meat. I'm going to talk about each one of these separately. Now, first, we're going to start with a case example, okay? And the old way. And by the old way, I mean how I've done it for many years. Kristen said, I was in practice for 38 years. I didn't do a very good job of this for a long time until I became aware of it as a problem. So I'm giving you any example of how I don't think is the best way to do it comes from my own practice. I'm not just making this up. Anyhow, Mr. E is 54-year-old white male with a history of hypertension, and I prescribed him 1 pill a day, lisinopril hydrochlorothiazide, a combined pill daily for the past year. His blood pressure on this visit is 165/98. I ask him, and he says he's taking his medicines regularly. His last refill of this medicine per the electronic health record was 100 tablets 5 months ago. He denies any symptoms. Now, I think we all can figure out 1 tablet a day, 5 months, 150 days, 100 tablets. There may be a problem here. Okay, so here's my example of how I used to do this. I see your last refill of your medicine was 5 months ago, so this means you're not taking your medicines regularly. 100 tablets won't last for 150 days unless you have some sort of pharmacological horn of plenty. Don't you know how dangerous this is? Mr. E, I suppose I do miss a dose occasionally, but I must have had extra pills from an earlier prescription. Your blood pressure is way too high today. Don't you know this could cause a stroke, heart attack, kidney damage, or worse, you could even die from that? Is it that bad? Doctor? Unless you change your ways, these bad things could and probably will happen to you. So what can I do, doctor? Well, it's very easy, You just need to take all your medications same time every day at the same time. You also need to exercise more often, reduce salt in your diet, lose 20 pounds, check your home blood pressures daily, reduce your alcohol intake, and keep regular appointments with me. Do you think you can do this? I guess so. Okay, everybody. Did any of you by any chance see anything that maybe wasn't completely optimal about that dialogue? I'm shutting up in case any of you have a comment. What would you have done differently?
You can type into the chat, or you can use the raise hand feature and I will unmute you.
Okay, well, if you want to respond later on, just feel free to do so. Oh, okay, we got something in the chat. Great.
Probably discuss why he may be missing doses, and then ask why or what barriers are present.
These are both great answers, and they involve talking to people. They involve talking to people and listening, which is going to be a lot of my recommendation here. Discuss why he may be missing doses. Absolutely good. Ask him, not the way I did there, where I was sort of yelling and scolding the guy. This does not bring out the best of human interaction and relationship, but to ask in a neutral way, why are you missing doses? What are the issues? What barriers may be present? Those are great answers. I have more answers too. All negative approach, not conducive to discussion, too much finger pointing. Yep, I completely agree with that. Does he have a pillbox? Great question. Give more SMART goals. Express a curious rather than furious tone. I love that. I also teach a class from MAVEN called Get Curious, Not Furious, when patients and clinicians disagree. So I love that phraseology. Very good. And discuss things that he could do to remind him to take meds. Put next to coffee pot. Absolutely. When you get the patient, him or herself, involved in constructive solutions, they're taking it on. It doesn't become your issue, it becomes a joint issue. Completely right. And get patient engaged in the care. Yes, and we're going to talk about how to do that more effectively. Get them engaged. And us lecturing people, or even very nicely telling people what to do without listening, without engaging them, is a limited success approach in many circumstances. So your answers here are great. Consider an app that helps them remember. That's also, for motivated people, a very good idea. Because I'm interested in medication non-adherence, several times a year people approach me and say, Dr. Kleinsinger, we have developed a new app. What do you think of it? I just recently got one in which patients They had to order their medications through this pharmacy, but then they got them in like a pill box, in a pouch, and the pouch had the pills for each time of day, and they put them in a machine, and then you have to enter into the machine, Tuesday 9 a.m. and out comes the pouch. If you don't do that, the machine contacts you. I was sort of mildly interested in that, but yes, get them involved. Consider an app. Considering any technical means that works for somebody. Check his understanding of health consequences of hypertension. Absolutely correct. Because the motivation for doing this is not just, oh, I want to see 150 become 130, because let's face it, that is not something that most people wake up in the day with great excitement. These numbers mean a whole lot more to us than they do to our patients. We want to make sure that people understand the consequences. And we're going to talk in a minute about best ways of doing this. So these are all great answers, and I really appreciate them. So moving on. Let me just shrink this down. So we're going to talk about some of those approaches. Shared decision making. This is a really important one. I don't know if you've been taught about this. When I was in my training, these words were not being used together in a sentence, but more recently they have been. In the model of shared decision making, the clinician and the patient collaborate to develop a treatment plan. And the first step is a mutual understanding of the nature of the problem, as you were saying earlier, including the risk if the condition is untreated or undertreated, and the principles of successful treatment of the problem. So we want to use shared decision making, and that means patients get a choice, and we're going to talk about that, about what to do first, et cetera, et cetera. Not just you need to do this, but here's some of the possibilities, here's why it's important, what would you like to try? Other communication tools. Teach back. I learned this at UCSF. I was probably doing it somewhat, but not so specifically. In teach back, we're checking our success in communicating. We ask the patient in a polite, friendly, non-judgmental way to teach you what they understand from the discussion. And for example, I use this a lot. I'm not always clear on that I communicate so well, and that a lot of patients sometimes say, I didn't quite understand what you said. It would help me. Could you just explain back to me how you understood what I said? Words to that effect. In other words, you're not making it look like they're taking a test, okay? You want to take responsibility for the fact that you may not have communicated clearly, or that the subject may be difficult to understand, and then ask them how they understood it, the whole thing or any component of it. And then comes the next important part of communications, is what I call the zipper lip. Okay, we clinicians tend to talk too much. So when you ask someone a question, shut up. Silence is golden. Because sometimes if you wait 10 seconds, the patient will just sit there looking puzzled or whatever. If you wait 30 seconds, they may actually start talking. And that's very, very valuable, because often there has been a missed communication or an incomplete communication. The patients won't take the medications unless they're convinced it's in their best interest. The only way we can know that we're getting through to them is by doing some sort of interactive thing like teach back. Another one, anticipate obstacles. This is another very good one. So you've talked about it and you said, okay, we've agreed that you're going to take your pills once a day in the evening when you brush your teeth, that you're going to check your pressure a few times a week with the blood pressure monitor we gave you, and that you're going to come back in 3 months. I mean, that's all great, but I know that sometimes my patients have trouble doing that actually once they set themselves. How might that be difficult for you? If you wanted to do that, what might prevent you from doing it? And then zipper lip, because you can get some good answers from them. I'm just too busy. I can't afford it, et cetera, et cetera. Any obstacles there, and then you can discuss them. Also, these are both relationship building tools. When you ask patients questions that are relevant, non-judgmentally, open-ended, and then listen to them, people really do appreciate that, as opposed to being told what to do. Doctor's orders really only work in hospitals. They don't work so well in outpatient settings. Self-monitoring. This is another issue that can actually help improve adherence. Partly because patients who can be motivated, say, to check their blood pressures or their blood sugars, can be this can engage them more in the treatment. If you're only getting feedback, say I'm using the mystical every 3 months when you come to an office, it could be much more, much less. And oh yes, your blood pressure is good. That's a very distant reinforcement. If patients understand what's going on, understand what's at stake, and understand the goals, if they're checking their sugars in the morning and they see, oh, I took my metformin yesterday and my fasting sugar is 118 and it was 172 the day before, this really works. So if you can get them to do any degree of self-monitoring, and the same thing applies to blood pressures, this engages them and gives them immediate feedback. And for the diabetic who goes to the birthday party and has pie a la mode and the sugars are out of sight, and then the next day they say, well, no desserts, I'm going to have a piece of fruit for dinner and for dessert, and the sugar is much lower. This is a teaching opportunity and a reinforcement that should not be missed. Now, how to get patients to do that regularly is another issue, but it all relates to the same kind of thing, which is that we want patients to want to do this. They want to see it as in their best interest. And immediate feedback, and this can be shown to enhance medication adherence. And also, as I said in the previous presentation, if they have been checking their blood sugars, blood pressures, whatever, regularly, and they stop doing it, that could be a sign that there's some issue coming up that's interfering with their care, and that would be worth investigating. But so if you can talk people into self-monitoring, if your clinic can give out the blood glucose monitors, or for more complex diabetics, I'm now recommending continuous glucose monitors. The price of those have come down. They're very easy to use if you have a smartphone, and they're immediately reinforcing without for example, the Libre Freestyle 3, you put a little thing on the back of their arm, and it takes about a minute to do, and it lasts for 2 weeks. Some insurances will cover that. And particularly, insurance coverage for those CGMs is better for people who are insulin dependent or hypoglycemic. I don't know what the situation is for you, but I've become a big fan of them because I think that they help with control and with adherence because you get immediate feedback. Involving family members or friends, and again, this doesn't always work. Nagging is often counterproductive if interfere relations, but if the patient, say, has a significant other, or it's a parent and they come with their grown child and they're getting along well, you can ask, can you help each other, with this? But sometimes that works well, but the non-patient, the person who's going to be giving advice, has to be encouraged to just raise it in a non-adversarial, non-nagging manner. We want them to be a team if that's possible, especially if the patient wants their support. And they can also help with things like putting medications in pill boxes, et cetera, et cetera, et cetera. But again, in a cooperative, you want to encourage us to be in a cooperative, supportive, not in a judgmental, accusatory thing. That is not very good for relationships and often doesn't work particularly well in the first place. Okay. More about communication tools that strengthen the clinician-patient alliance. This is one I learned the names for a while ago, and I love it. I statements. With I statements, you're talking as a person using the pronoun I. I'm worried that. I'd like you to try. I'm worried. Your blood pressure in the last 2 visits has been pretty high. I'm worried that something bad could happen to you. Compare that to, if your blood pressure stays this high, you could be in real trouble, or you obviously need to, I statements. I'm worried. I'd like you to try. I'm concerned. I'm interested in what's going on here. And always when you say something in the question, you shut up. Okay, even if they don't answer immediately, give them some time. People like that. So I statements, very important. It's another way of building, making it 2 humans sitting in a room together, not the authority and the patient, because the statistics that I quoted in the first presentation and this presentation beginning are very, real and valid. The existing system is not working particularly well. So I statements are more easily heard than you statements. Incremental approach. Many times chronic conditions, it isn't just the medications, and patients could be overwhelmed by being asked to do too many things all at once. And we've been taught this. Oh, New patient with diabetes. Well, you need to communicate with them all aspects of this to do a thorough job. And we, the medical profession, like to think that we're checking all the boxes. So in the parity presentation I did before, you need to, you're diabetic, so you need to stick your finger in a sensitive way on a daily basis. You have to quit eating every food that you like. You have to start exercising, which you haven't done in the last 10 years. You need to lose weight, very, very difficult. You need to take your medications regularly, and you need to, well, a lot of people, even though we are very pleased with ourselves, oh, I've covered everything, isn't that great? If you're on the receiving end of this, it seems like a ton of bricks, and for many people, they're overwhelmed and they tune you out and they start thinking about, well, let's see, I'm hungry and I see there's a McDonald's around the corner here. What am I going to get for lunch? And as you're yammering on about all the things they need to do. If you suspect this may be happening, and it usually will be, ask the patient, we've talked about several things here, and I know you can't do them all at once. Which would you like to try first? Getting back to shared decision making. And I really want to emphasize this because for most people, we have now changed our definitions for diabetes and hypertension about what they are, particularly for hypertension. Lowered blood pressures are now considered abnormal. There's no rush on most of this. If someone comes in with a 220 over 140 blood pressure, I take that back. That's an emergency. If someone after 3 visits is 152 over 84, they current standards need treatment, but you're in no hurry on this. If the patient says to you, I've read about this. I understand you think medications will help, but there's some things I'd like to try first to see how they would work, or you could suggest that. But if they say, I understand that if I cut out on salt some and maybe eat a little bit less and I want to exercise 3 minutes 3 times a week, I've been thinking about that. I would like to try that first, at which point, especially if it's just the normal, relatively mild elevation, or even if it's moderate but not serious, I say, good. Great, go for it. And what I'd like you to do, if you're going to do that, is to keep track of your pressures, write them down, or if you have a meter, bring it in your next visit, or a CGM, you can send it to me online, and we can see how that's working. And if that's working, fine, great, we can stop there. And if it's not, we can talk about other elements. So again, we're working as a team, we're collaborating, we're not trying to overload people with everything all at the same time. So, and when element A is successful, you can say, well, great, your pressure has come down from 150 to 142. That is a big improvement. With current standards we'd like it closer to 130. So why don't we add this component to this too, and then keep doing what you're doing, and we'll add this. How does that sound to you? And that you're on the road to success when you can get to that level. A related concept is self-efficacy. And success begets success, and the converse is also true. If we fail at something, we're discouraged. So another reason for the incremental approach is that patients who succeed at one treatment component, great. You've watched your diet, you've lost 6 pounds, your pressure is great, you're doing really well. Now what can we add to that? They are already feeling more confident and motivated. And again, Rome wasn't built in a day, exception for seriously out of control things, which is a different issue altogether we won't discuss today. Habit forming. Now, doesn't that sound negative? This drug is habit forming, whatever. Anyhow, we tend to, as clinicians, we tend to think of bad habits, as hard to break, and we know that they're hard to break. Any bad habit is hard to break. Look at drugs, alcohol, inappropriate eating. I could go on, a lot of other risky things that people do. Bad habits, smoking. Oh my God, but this can be true of good habits too. Once they're established, they're harder to break. So, and the literature, the medical profession has not studied habit making as much as it should, I think, because a lot of this stuff, we want to make it habitual. And by habitual, I mean something that we do semi-automatically without thinking about it. I'm assuming that many or most of you brush your teeth at night. Do you wake up in the morning and think, or in the morning too, gee, I think this is Thursday, I'll brush my teeth today? Or is it semi-automatic? You're getting ready to go to sleep, you wash your face, you pee, and you brush your teeth. You want it to be taking medications, any of the things we're talking about, but particularly medications, you want it to become as semi-automatic as that. And so one of the ways you can help people make good habits is repetition is key. I've read in the literature without any good evidence to support it, but I'll say it because I don't have anything better to say. Doing the same thing at the same time each day for 6 weeks and it becomes a habit. I don't know if that's true, but I think that elements of that are true. We want to make it semi-automatic. I personally, I sometimes forget and I go to lie down in bed and I think, oops, my mouth feels fine. I didn't brush my teeth. I have to get up then because I will not rest until I do so. And you want the same thing to be about pills. You want it to be semi-automatic, and we can reinforce that. Self-monitoring can aid to the habit process. If someone's taking something, as I said before, irregularly, and they know if they're self-monitoring, they notice that their pressure, sugars, whatever, are not, on the days they don't, are not well controlled. This is reinforcing, but we want it to become a habit. Okay. So case example, we're going to repeat that same case. And if anybody wants to, please think about what elements you would do if you were doing this. The different, again, the same patient, he's been prescribed lisinopril and he hasn't taken all his medicines for your EHR thing and his pressure is too high. Does anyone want to put into the chat or raise their hand and say what would their next step would be with him? Any component of it. You don't have to do the whole thing. Okay, I'm getting some chat. Recheck blood pressure. Okay, worth doing. Ask about side effects. Always a good thing to do. Yes. Are you having any problems with your medication? And as I said in the first presentation, when we ask about side effects, don't forget fear of side effects. People that, that's very real. But some side effects patients don't like to talk about also. For example, with men and blood pressure medicines, I just don't like the medicine. Oh, why not? Well, yeah. Do you have any problems? Does it have any negative effect on you? Well, I'm having a little more trouble getting erections than I used to. Oh, okay. Well, that actually can be a side effect. And the good news is that if we change your medications from this to that, that's much less likely. I really appreciate you bringing that up because, I know that's upsetting to you and that would be an obstacle to you taking the medicine, but that is something that we can deal with. The pressure in the office can be up from walking and driving. Absolutely. The current standards are that and it doesn't happen nearly as much, as that when you're checking office blood pressures, you do it once, you wait a few minutes, you do it again, you do it with their arm at the level of their heart, etc., etc. But I know from my own experience when I go to the doctor that sometimes it's, okay, come sit down, check your blood pressure, check your temperature. Okay, the doctor will see you now. And you're not getting the most accurate reading. When did he last take his meds? Yeah, sure. Good question. Again, if you can try and ask it non-judgmentally. And then also, so that's fine for now. And then again, this is a reason to revisit. A lot of my patients do have trouble taking medicines regularly. It's very, very common. And sometimes that's because I think that I have not been successful in getting across to them why I think this is so important. So let me just ask you, why am I making a fuss over this? Why do I think this is important? And zipper lip. So all those things are relevant. You can apply these things. So I just asked that. So this is what I just said here. Clearly difficult. What's hard for you about taking the medicines? Do you understand? Have I been clear about why this is important? What questions do you have about this, et cetera, and start and continue a dialogue. I don't know if you're looking at me, but there's sun shining in my computer. Give me 1 second. I'm going to take care of that. I have a skylight here, which sometimes today interferes with people getting a look at my face in case anybody likes to do that. There we go. So, and getting to the last phase of approaches to this, the team approach. As many people have said, it takes a village. We clinicians are very, very busy. We do not have enough time to do everything that's expected of us. This has been well documented in many ways. So I don't know what's available in the clinics that you're working in, but other members of the medical team can help the patients improve their medication adherence. It's not just the clinician's responsibility. Uh, for example, identifying non-adherent patients. In many clinic settings, we only take care of the patients we see. So if the patient remembers to make an appointment, great. But there are many people who stopped taking their medications or aren't taking them regularly who've also stopped coming in. If we can find them and bring them in, I consider that the low-hanging fruit. Someone who hasn't been taking their medications, if we don't see them, we're not going to have any effect on them. But so if you have a medical assistant, nurse, or anyone who can review the EHR for patients with relevant diagnoses, I'm talking about hypertension, diabetes, those are the commonest, but any chronic condition, looking for patients who haven't been seen in a long time. Can you ask your EHR, please give me a list of every patient of Dr. X's who has a hypertension diagnosis who has not been in the clinic in the last year. Some EHRs are capable of doing that. And then contact them to set up follow-up appointments. Or also review not just showing up, but people who are meeting target. Is it in the EHR? Can you get this out? The people with blood pressures above current standards, or diabetics greater than 7.5, or can review medication refill records if these are readily available, looking for medications that are not being appropriately refilled. I worked, I think Kristen mentioned this, I worked at Kaiser Permanente for the last 21 years of my career, and in some way that made it a bit easier because of the fact that most Kaiser patients got their medications from Kaiser. So I could look not only at my list of when did I refill this last, when is it refilled last, but also when was it filled last. That's not always possible, but any way that you can have people looking at those things and identifying patients and bringing them in, then that's better than relying upon them to do it themselves. Because if there's an inheritance problem, there may very well be a keeping appointment problem or any other aspect of what we're talking about for healthcare here. So identifying them. And so the other issue besides identifying them is, does your practice have anyone other than you clinicians who can counsel and support patients? For example, do you have clinical pharmacists, or do you have pharmacists who can talk to patients? Are there chronic disease management programs? Are there diabetes management programs or classes? I have found that particularly with clinical pharmacists or nurse case managers for diabetes, that sometimes, even though I think I've been really a good communicator, that hearing from somebody else who may have a different approach, or maybe just hearing it from more than one person, that can be very effective. So I really, to the extent that you have anybody else who systematically can help with this, I recommend that. And that would be something to talk about perhaps at a clinic staff meeting, if you do or don't have these people, about how to use them or how to use them better. You clinicians, we clinicians are the most expensive and the most time limited, busiest of usually of anybody with the greatest responsibility. So anything that you can unburden yourself and have somebody else do can be a major effect. And so we're talking individual things we can do as clinicians and systems things we can do in practices. Hopefully at some point in the country, there'll be more national movements in this than there are right now, but we just have to deal with the reality we have. So in getting ready for conclusion, again, as I said before, I encourage you to develop your own practice plan for improving medication adherence. And just as I said, for patients, that change requires education, motivation, commitment. For you to change also requires education and motivation, which is what we've been trying to do in these two sessions. Commitment, you're coming to this, I think you're probably interested in this, and a specific plan. So my goal, your goal could be right now, before you do anything else, write down a few, again, let's start with one thing, two things, incremental approach. What elements of the things we've talked about that you could do as an individual practitioner regarding prescribing, communication, your troubleshooting, or as a clinic, which things would you like to try first? And then, since prescribing medications and following up on medications is something we do daily, you use whatever tool that you are working on. If you are willing to do this today or tomorrow, start doing it now, because if you don't, I guarantee you that most of you will forget about it in the press of all the other urgent things that come to your time. So that's if you do that, I think that you're going to improve your success. You're going to make your patients happier and healthier, and who doesn't want that? So anyhow, the goals of this presentation to give attendees an overview of techniques and to facilitate development of a specific adherence improvement program for participants to use themselves and in the practice as a whole. And I hope we've been successful for this. So I want to ask the group my last question. For any of you who are interested and motivated, what will you start doing in the immediate future? Can you, again, put that in the chat or raise your hand? I'm interested. We're at the end now. So if anybody has any other comments, questions, criticisms, feedback, I'm all ears. Teach back, somebody wrote. Right. Shut up after asking questions. Excellent. I'm sorry if I use the slightly rude term, sir, shut up, but I mean it. Anything else? Ask what are their potential barriers. Yep, really good one. People like that. You're taking them seriously. You want to know who they are, what's going on with their life. Okay, well, I'm pleased to be getting these responses. Use phrases like "I'm concerned about." Absolutely, good one. If you try that, you'll find that people like it. And actually, a lot of these, by the way, just a lot of these communication techniques are pretty useful in other aspects of your life. One goal at a time. Yep. Assume responsibility for good communication. Yes. This makes us human. This takes the patient very seriously, and we're open to feedback, and we want to work on doing a good job and answer people's questions. It's very hard to know what people understand. People come in with all different degrees of health literacy and attention, education, concerns about other things. So if we assume responsibility for good communication, it's going to improve communication. Okay, well, that's great. And I want to say I really appreciate all the feedback and interaction we've had during this presentation. It makes me feel that I'm being effective and that this can be a good approach. And I appreciate you all coming, and I wish you the best of luck with this in your practices. The lack of success in improving medication adherence sabotages a lot of the good work that we think we're doing. And someone's thanking me. You're very welcome. More thanks. Thank you. And I thank you for attending, and thank you for taking this seriously. I really appreciate it. As people say about me about this, it's a passion of mine, and I always appreciate it when I can share my interests and concerns with people.
Well, thank you very much, Dr. Kleinsinger. This was wonderful. I'm just going to pause in case there is any last minute questions. Please feel free to put them in the Q&A box for the chat. And just a reminder about the CMU survey. I'm going to really harp on it today because Dr. Kleinsinger also presented last Thursday. So if you do not get the correct date, and make sure that it says July 18th, there is a chance that you're going to have a serious issue with your certificate, and I'm going to have to sort that out and make sure that it's applied to which session. So please really be cognizant of which date you are putting in. Otherwise, you might get 2 certificates for last week or none. See how it goes. All right.
Okay. Well, good luck, everybody, and hope the rest of your day goes really well. I'm going to sign off now.
All right. Thank you so much. Have a great day.